you, folks. Real pleasure to be here. We have no relevant disclosures for this presentation. Our objectives today are to understand communication strategies for end-of-life conversations. We'll review normative approaches to surrogate decision-making at the end of life, describe empirical evidence around patient and family decision-making at the end of life, and we have some cases at the end, which we hope to be interactive, so we'll apply some of those frameworks. So to start off with, end-of-life communication falls on this continuum and under the umbrella of serious illness communication and advanced care planning. And maybe even the reason I have two different words there, serious illness communication and advanced care planning, is there's some debate in our field of what to call this process. So, advanced care planning may be what we're doing for people that are healthy, where there's not a context of illness and people are naming a healthcare proxy. They may be talking to their important people about completing advanced directives, but there's not a context of illness to really make specific healthcare decisions. Well, we think as palliative medicine doctors that we do serious illness communication, and that there we actually do have a serious illness as the contextual basis, and there may be more of a clinician participation rather than family communication. There you're maybe making specific decisions, maybe even completing a pulse form. And this is, again, on a trajectory. And at the end of life, you have an end-of-life talk. But what really is the definition of then advanced care planning? Well, 2017 large Delphi panel agreed that the consensus definition as a process that supports adults at any stage of health in understanding and sharing their personal values, life goals, preferences regarding future medical care. That's pretty broad. Future medical care, sometimes I call it healthcare emergencies, and it's based on values, goals, and preferences. With that broad definition, I can even say that end-of-life talk falls under that broad definitions of advanced care planning. But obviously, there's not enough palliative medicine clinicians to provide advanced care planning and communication for every healthy and ill individual in the United States. So we are often teaching palliative medicine principles to others. And I think that truly some of the principles that apply to end-of-life talk are the same principles that apply at any stage of illness, anywhere upstream. So, I think that very much end-of-life talk is still talking about future medical choices, but maybe those medical choices have narrowed, and maybe you are now talking about something that's not very advanced. It's proximal, and that is now proximal. And maybe you're making decisions more on death delaying, and you're talking to people about how they view their deaths and how they want to shape that process. But I still think very much so that those conversations are going to be based on values, goals, preferences. I think, in advocating for serious illness communication at any level, I think at any part of this trajectory, we have common frameworks, but we'll also highlight some of the more specific frameworks for end-of-life cases. I think our approach for this conversation was we took kind of a narrow view of end-of-life talk and end-of-life communication. So to reference Tim Elder's talk from last week, the folks that were here, I think we will have cases, and there are cases that have little prognostic ambiguity, where we feel confident that this is an end-of-life conversation, and sometimes the conversation techniques there are a little bit different. So this is a serious illness conversation guide that I really love to use. This is from the Mass General Brigham and Women's Health System. It's called Ariadne Labs, and our fellows that are in attendance have seen this. We use this a lot. I really love it. But how does it actually correlate with end-of-life communication? There was an article in the Journal of Palliative Medicine in 2023 titled End-of-Life Communication Strategies for Health Professionals, a Scoping Review. And there they identified 7 themes for end-of-life communication. So preparation, exploring and assessment of information, family involvement, provisions and tailoring of information, empathic emotional responses, reframing or revisiting goals, and a conversation closure. And I think that actually really maps on really well to this serious illness conversation guide and this the patient tested language that we have here. So just to walk you folks quickly through this, very much so, yes, even in end of life communication, it's very important to set up a conversation first to have all your information at hand and speak with all the treatment teams that will help you think about the illness context. But also getting permission from families and patients to speak. Is it okay if we have this conversation? It's super important to understand where patients and families are at with illness understanding. That may be phrases like, what is your understanding of now of where you are in your illness? Then I think sharing prognosis and sharing information is extremely important. I have that one circled because we'll revisit that. I think it's extremely important in end-of-life communication. And then exploring key topics, right? We've been touching on this already, but I think that this is important at any stage of illness, but still very important at end-of-life conversations. I think my favorite kind of aspects of these key topics to use at end of life are the trade-off and critical abilities questions. Why those? I think those can sometimes be really well framed around an end of life context. So a trade-off question may be with a surrogate, maybe what would mom give up for the possibility of more time? What would she not give up? And sometimes even highlighting that idea of it's the possibility and not the guarantee of more time. And in a way, you're doing a little prognostication with that kind of question. And for an abilities question, critical abilities, it may sound something like, what abilities, either physical abilities or mental abilities, would be critical for her to have? What could she not live without? And I think that may help you, especially when speaking with surrogates, still get to some very important values and preferences about the patient. And moving on, the closing of the conversation, there are statements you should make about summarizing what you've heard and making recommendations. I think is really important. So I've highlighted this, and we'll revisit this this topic, making a recommendation. So where are we on the illness trajectory? Very, very, very important for end-of-life talk, end-of-life communication. This is where you are sharing your prognosis. I mean, think about just how important this is in end-of-life communication. Again, it's very important at all stages of communication, even for your healthy person or your person living with chronic stable disease. It may frame the conversation, but it's so important to frame for patients and surrogates that maybe the decision they're making is, again, not one to extend life for months, maybe even years, but it may be decisions around that end-of-life course which they've already entered. And I think it's important in these situations to use the word death instead of euphemisms for death. What might that sound like? That may be statements like, I'm afraid no matter what medical intervention we offer, she is dying and her time is short. And that's a very clear, short, concise statement of death. And you may get a response, and you may get questions about how much time. And then I think then you pivot off of that, and you talk about your best estimate in terms of ranges. And people may ask things like, well, does that mean you're giving up, right? And then I think you can pivot to things like a plan. We can focus on the possibility of more time and trying to delay death, or we can talk about a focus on comfort and symptom control, and that leads to a broader discussion. But I think that really speaks to those ethical principles of veracity and truthfulness. Making a recommendation, super important in end-of-life communication. I think it's really important to not make recommendations in a vacuum. What does that mean? that essentially means don't have like a recommendation statement rehearsed and know what you think you're going to say to the patient before you've actually spoken to the patient or the family. So you don't leave a recommendation before having that discussion about the prognosis, about their values, about their goals and preferences. And a good recommendation draws upon medical facts, but also draws upon those values. I've heard a really nice statement in palliative care: you don't have an agenda. You don't want to enter the room with an agenda, but you have expertise. And that's what you bring to the case. You have expertise in people that are ill. You have expertise in these illnesses that you've seen before. I think I like to especially teach this, trying to avoid language when we make a recommendation, because it's not quite a recommendation of phrasing things as, would you want us to? Would you want us to do this? Would you want us to do that? A menu of choices. And rather, I think a recommendation is guiding people with synthesized information. I also think it's really important that recommendations for comfort care should truly align with values, right? I recall a case when I was a resident where a surrogate decision maker told us that my mother would bond be alive even if she was a head connected to a breathing machine. And I think that kind of statement, that's not to say that a person that says that may never receive supportive care only, but I think that's what I'm hearing there is that, yes, prolonging life almost to the greatest extent that is possible under reasonable medical standards is the goal, right? So I think that once those reasonable medical standards have been exhausted, yes, so there may be a recommendation for supportive care, but maybe not beforehand. And maybe there we're offering alternatives. Maybe it's another meeting. Maybe it's time-limited trial. Maybe it's non-escalation of the current care. And making a recommendation, I think, is really important as part of informed consent, which we'll revisit. But what may a recommendation sound like if it's both guided by a patient's values and preferences and your clinical expertise? And maybe I've heard your mother found it essential to communicate with her family and live independently. Given the severity of her illness and those preferences, I would recommend against escalation of her care to the ICU. I would instead recommend that we focus on managing her symptoms and having family join to be around her. And I think that's actually even a little more than just saying keep her comfortable, which I think is almost like a buzzword for the comfort care route. So far I haven't talked about empathy, right? It wasn't in that other conversation guide, but this is extremely, extremely important. And empathy goes a long way in communicating with patients and families. Essentially, speaking about death may be something regular to you, and maybe another Wednesday afternoon. But for families and patients, it's life altering, and especially for families, they're the survivors of this, right? So I think like using empathy and trying to respond to emotions appropriately throughout the discussion is super important. And yeah, true empathy is not sympathy. I think there are statements that may sound like, yeah, I know what you're going through. That's not an empathic statement. That's actually a statement centered on you. An empathic statement may be quite the opposite. I can't imagine what you might be feeling and what you're going through, because we truly can't. And I think perspective taking is really important for aligning your emotions and when you feel at odds with the decisions of families and patients. And this slide I added because I really loved Tim Elder's talk last week. I had a little bullet point on the previous slide that empathy is genuine, but I even think it's a little more than just empathy. I think like the way we communicate with patients and families has to have a level of authenticity. He mentioned that there's no virtue that's specific to palliative medicine. And I think I totally agree. There's no moral high ground that like palliative medicine docs hold that other specialties don't, right? I think there's wonderful doctors and all other specialties. But certainly when we recruit people for our field, and I can speak to this as a fellowship medical director, is that we we hope that people have that honest desire to be with suffering, to be with patients and listen to them. And that's the virtue we're looking for. And I think that communication that's honest and authentic is emotional reflective, it's genuine, and maybe it's even original, right? So I think, the interesting question I have is, how does that actually interact with the standardization that we have in medicine, the evidence-based medicine approach that we take? Is that conflicting with our authentic communication? And I'm maybe answering my own question, but I don't think it does. I think even with our fellows, we try to teach that there's some standardization, there's some frameworks, but you have to be adaptive. I don't expect anybody to speak with the same phrases or write down what I've said here and like regurgitate a patient, right? So authenticity is truly that human factor. And there's been some interesting studies with using artificial intelligence. So I just want to bring this up. It's kind of fun. But when patients were given human attribute responses versus AI responses, they consistently found the human attributed responses to be more empathic and supportive. And when participants believed that AI had aided the human attributed response, that reduced their perceived empathy and support. So people consistently chose human interactions over the AI ones. But when third-party analysis instead of patient analysis was used, those actually preferred the AI responses, more compassionate than human responses. So I think that's pretty interesting. To me, that says that the how and the who matter, not necessarily just the content of what you say. And I think the final point, as I turn it over to Hanna, is that every clinical challenge can be resolved with communication. That's like really, really important to remember, is that even if you pour your emotions into it and you feel like you really have covered great ground, have great content to what you say, there's so much more in how people navigate illness than just that hospitalization, that interaction. That there are still going to be challenges that remain. So just saying that we're going to provide better communication and educate everyone how to communicate better, that doesn't always solve everything. I mean, there's also so much on the healthcare law and other levels like that are important. But I digress. But I just really want to leave it with that point as I turn it over to Hanna.
All right, thank you so much for all of that. As you, even sort of with your comment that communication cannot solve everything, I think in case conference, we often talk about how ethics consults come from breakdowns of communication. Yeah. And so I think reviewing all of these skills and giving us some practical approaches for how to go into these conversations with patients and families is really useful. So I'm going to shift now to talk a little bit about normative approaches to end-of-life decision-making, as well as what the evidence shows about how clinicians actually do this in practice. You heard from my introduction that I'm a pulmonary and critical care fellow, so a lot of the perspective I take on this is based on my own experiences in the ICU. And so I'm going to take the specific lens of end-of-life decisions that occur in the hospital, and my specific interest is around surrogate decision-making at the end of life. And so a lot of the information I'm going to talk about and evidence I'm going to present is around surrogate decision-making specifically, though I think it can also be extended to patient communication as well. So speaking about end-of-life decisions in the hospital, no surprise to this audience here that modern medicine has certainly changed the landscape of what death looks like. Most patients will spend some portion of the last weeks of their lives in the hospital and in the ICU. And in the ICU specifically, about 60% of deaths occur due to a decision to withhold or withdraw life-sustaining therapies, right? So this is a really prevalent conversation and decision that's coming up in the critical care context. And it means that there has to be an active decision on behalf of patients, surrogates, or clinicians to either not proceed with a therapy or to withdraw or discontinue it. And because patients are often critically ill when they get to this stage, they're often unable to engage in those conversations themselves. And so we end up relying on surrogate decision makers who are most often close family members and who know with varying intimacy and certainty what the patient's values, preferences, priorities around treatment are, what their prior wishes are. And so because this is a really prevalent decision, because it's burdensome, value-laden, preference-sensitive, certainly critical care societies have identified communication between patients and surrogates as a really important aspect of high-quality critical care. I would say like the framework that's generally put forth by these guidelines is that of shared decision-making. So I think of that as having 3 central components, so that's sort of paring it down, but the first being sharing of medical information, as well as sharing by the surrogate of information about the patient. The second piece being active deliberation that happens in a 2-way method between the clinician and the surrogate decision maker, and then ultimately coming to a decision. The way we do this matters a lot, right? It matters to ensure that patients are going through the process of end of life and dying in a way that's concordant with their goals. But it also matters from the surrogate perspective too. I think in critical care generally, we've had an increasing recognition in the last 10 to 20 years that like the things we do in the ICU impact patients and surrogates not only during that ICU admission, but also down the road. And there's a lot of research into post-intensive care syndromes for both patients who are survivors of ICU stays, but also family members. And family members who have patients who survive an ICU stay and family members who have loved ones who don't survive that ICU stay have high rates of poor mental health. So in the literature, rates of depression, anxiety, and PTSD among all of those families, so all comers, are as high as 40% up to 3 months after an ICU admission. And I don't think that communication is the only thing that plays into it, right? The experience of being in an ICU, the experience of having a loved one going through this, as well as the care that they continue to require post-ICU certainly contributes. But there is research that shows that like the way we communicate does contribute to these mental health outcomes. So I highlighted a couple studies there, but there's been higher rates of PTSD demonstrated among surrogates who feel that they made an active decision at end of life versus surrogates who were told that their loved one was at the end of life by a clinician, and higher rates of PTSD among those who report decisional conflict. And so what I mean by that, and I'll show some data in a few slides, is that people have different preferences around how much control they want over decisions, right? There's some people who want to make decisions independent of clinicians, and there's some people who would rather that decision is placed in the hands of the clinician. And for those people who felt that there was a discordance between how they wanted to make that decision and how it actually happened, they have higher rates of PTSD in these studies. And so I think, the reason I put this all up here is just to say, like, the way we talk to people, while it's not the only thing that goes into mental health outcomes, it does contribute to their experience after the ICU. So to shift to talk a little bit more specifically about normative approaches to end-of-life decision-making. From an ethics perspective, we've certainly swung the pendulum away from paternalism to a heavy emphasis on patient autonomy. And in the context that I'm mostly talking about, that's manifested through surrogates. We ask surrogates, what would this person want if they were able to tell us? But I think that there are perhaps some problems with that approach, right? We're asking people to come to like this Goldilocks kind of unknowable decision. And we know that our experiences shape our decisions, but we can't hear from the patient how this experience is shaping their current decision. And so that's why I think that perhaps a little bit more balanced of an approach is one to consider. And I will credit a lot of my thinking around this to the substituted interests and best judgment framework by Dan Solmese and Lois Snyder, as well as Dr. Brudney and his approach to authentic decision-making rather than purely autonomous decision-making. But to walk through what this approach kind of looks like, and I think it aligns with some of the things that Vasyl was talking about in terms of recommendations. Like this, I think we can't remove like the clinician expertise, experience, and professional autonomy from these decisions. As I said, experience shapes the decisions that people make, and people often don't have the background to fully understand the medical information and medical context of what's happening to them. Additionally, there's a lot of inputs into like what that decision that the patient would want looks like. So things like values and preferences, what their known wishes are from prior advance directives, acknowledging that that maybe shouldn't be the line in the sand entirely, but can frame some of the thinking around how they might approach this decision. Because as I said, experience shapes that decision, and they weren't in the current context when that advance directive was made. Other things are cultural context, religion and spirituality, interpersonal relationships. That list can go on. But I think the idea of this approach is moving away from sort of a purely autonomous decision, recognizing that there may be some circumstances where like we know what this person would want, right? You set up a situation where like it was clear what that decision for this patient would be. But when we're operating a little more in that gray zone, which is the gray zone I think we most frequently operate in, allowing for both inputs from the clinician side and weighing more heavily the patient side, but a little more equal balance. And so I won't walk through this again, but this is the substituted interest and best judgment framework from Dan Solmasi and Lois Snyder that I think is reflective of some of the things that I put up on the last slide. So that's like how this can happen in an ideal world, right? But what does the evidence show about how it's actually occurring in practice? And so I'm going to walk through some of the empirical evidence we have around life-sustaining treatment decision-making, which is often equivalent to end-of-life decision-making in the ICU. And a lot of this evidence is based on audio recordings of family meetings and qualitative analysis of those recordings. Some of it is based on surveys of surrogates, and some based on simulation studies. So this first study was sort of the landmark paper using audio recordings in the critical care space, where they used 50 audio recordings from 2 different centers on the West Coast, and they organized the approaches that clinicians took to end-of-life or life-sustaining treatment conversations with surrogates in the ICU. And the frames that they put clinicians into sort of ranged from pure autonomy, where clinicians just provided information, left the ultimate decision in the hands of the surrogate, to pure paternalistic, where the clinician was directive and took control of the decision. In the middle were these facilitative and collaborative frameworks, which I think align most closely with the shared decision-making principles I talked about. Where facilitative, they elicit values and preferences, and collaborative, they take it a step further to actively deliberate. I think encouragingly, like over 80% of clinicians were approaching things with a shared decision-making framework. This was a smaller study though. Attendings were the main people carrying out these conversations. And so this group and others did some follow-up studies to gain more detailed insight into how these conversations were happening in practice. And so this is a summary of some of those follow-up studies. The biggest study is a study from Doug White out of Pittsburgh that includes like hundreds of family meetings happening at multiple centers across the country, held by both residents and attending physicians. And in these studies, they found that in only 50 to 70% of family meetings was there a discussion of patient values or quality of life considerations, which I think speaks to perhaps some need for improvement based on the approaches that both Vasyl and I have set up. In only a third of those meetings or less was there actually a recommendation being made by a clinician, and in only 8% of those meetings was the recommendation actually grounded in patient values. The recommendation was more frequently made in the context of what was happening medically to the patient. it of course begs the question of what do surrogates actually want in these conversations, right? Like we're putting out these communication strategies, we're putting out these normative approaches, like does this actually align with like how surrogates want this communication to happen? And so this next study was a study where they asked surrogates to read two different like scenarios, and these were surrogates who had a loved one actively admitted to the ICU. And the first scenario was one in which there was a decision to be made about a life-sustaining treatment. And in the other, it was where there was a decision to be made about antibiotics. And they asked them, how much input do you want from a clinician on this decision? And so there's a little bit of a split here, both in two ways. The antibiotic choice is in black, the life-sustaining treatment decision is in gray. And you can see that when it comes to antibiotic choices, surrogates are more willing to have the clinician make the final decision. Interestingly, I think they want more input than we probably give them in clinical practice. Like over 25% of people wanted to share the decision responsibility about antibiotic choice. And then when you look at life-sustaining treatment decision, about 85% want to either share the decision responsibility or make the final decision after consideration of the physician's opinion. So there's been, more studies than this one in a little more mixed. But I think the thing to highlight here is like not everyone wants that, right? 10% want to make the final decision by themselves, and a minority, but some want the physician to make the final decision. And so I would advocate that this data also speaks to the fact that we should be eliciting people's decisional preferences too, as part of our shared decision-making approach to figure out how we can best support them through this experience. Shifting a little bit away from recommendations, I put this slide up here because we're talking about communication strategies, and there's literature out there that shows that the way we word things matters. That probably makes sense to all of you inherently, but there's been specific research around like how does the way that clinicians frame decisions about life-sustaining treatment or end of life influence what patients or surrogates choose. And so this comes from like decision science. Some of you may be familiar with the idea of decision framing, which is like the way that we present a decision influences the ultimate choice that someone will make. So like the classic example of this is like if you put up a yogurt that says it's 90% fat-free versus a yogurt that says it contains 10% fat, everyone's going to pick the 90% fat-free yogurt, even though they're identical. So like the way information is presented influences what people choose. And this is similar to the idea of nudging, where like the words we say, the way we present things influences decision-making. And I think we know and understand this to some degree, but research among clinicians shows that while they see framing as important, they often don't know how the way that they frame things is influencing decision-making. And so this was a study of surrogates to see how framing influenced their choice around life-sustaining treatments, specifically code status. And so surrogates were randomized to watch different videos. They randomized either receiving like emotional support during the video or not, and then also varied the language that the clinician used in the video around code status. And they found that emotion didn't actually matter for the decision people made about code status, but the language around code status was what ultimately influenced people's decision making. So when CPR was framed as the norm, people were more likely to choose it versus when no CPR was framed as the norm. And then when the clinician framed the alternative to CPR as a DNR, people were more likely to choose CPR. But when they framed the alternative to CPR as allowing natural death, people were less likely to choose it. And so I think that framing can be a powerful tool when we understand people's values and preferences, and we're using that to make decisions about how to frame things. But it can also be dangerous when we're not aware of the impact that it's having. And then, as Vasyl mentioned, we have some cases that we'll review next. And when we approached this presentation, we were really thinking about it from the perspective of people who were at the end of life and were making decisions about what they wanted death to look like. But certainly in medicine, we often are handling a lot of prognostic uncertainty. Even at the end of life, there can be uncertainty about how much time remains. But in other situations, not just end of life in the hospital, in the ICU, we often have uncertainty about patients' prognosis and long-term functional recovery. And I think the question often comes up of like, how should we handle and communicate that prognostic uncertainty? Like, how do we ensure that surrogates are equipped with the medical information they need to make a decision when we as clinicians are uncertain about what that medical information means for long-term prognosis? And I don't have the answer to this question because I think that's one of the hardest things we do. And that's what some of my research this year is focused on, is how to handle those conversations in the face of prognostic uncertainty. But I think we still have a duty to communicate to the best of our ability, like what prognosis is. And in studies looking at audio recordings of family meetings, they've found that clinicians use a variety of different probabilistic statements to handle this uncertainty, saying things like, it's very likely he won't survive. I worry that he won't make it through this ICU admission. They tend to use qualitative statements, not statements that are numerical in nature. And when they look at how surrogates interpret this, they interpret it much more optimistically than clinicians do, both in terms of these qualitative probabilistic statements and in terms of numerical statements. There was this study where they gave surrogates like a number. They said 90% chance that this person does not survive this ICU admission. And they interpreted that as the chance of death was the chance of death was less than 10%. So more optimistically. And so I don't know what the answer is as to how we handle this prognostic uncertainty and ensure we're being clear with surrogates about what it means. I do think one tool that's actively being researched is like the best case, worst case, and time-limited trials, which is largely coming out of University of Wisconsin-Madison with Jackie Cruiser and Gretchen Swartzy. But that allows both clinicians to frame for themselves, like, what does the best case outcome for this look like? What is the worst case? And what are our markers along the way that show us whether we're making progress toward either of those goals? And I think that helps both clinicians and that helps patients and surrogates to frame what progress might look like. So that's what I have. We can pause for a minute just to see if there's any questions now. And if not, we'll move into talking through our cases. Yeah, well.
Fantastic talk. My question is about the prognosis and thinking about the first slide where you point out that the majority of ICU deaths are because of withdrawal of life-sustaining.
Mm-hmm.
So as life-sustaining treatments continue to advance, there are fewer and fewer patients who can't keep alive in the short term. And eventually, you do have patients who die from fractures, maybe from a shot. But the prognosis is a function of decision to withdraw life.
Sure. Mm-hmm.
More so than the actual, in terms of the kind of days. And so how do you think, given the advances in life support, that this whole framework should progress? So what's the right conceptual framework for prognosis?
I mean, I think that perhaps there has to be then two different sharings of prognosis that occur, right? Like you share medical information when you initiate these conversations to help give patients and surrogates an initial framework as to what is happening. You elicit values and preferences, and then maybe you're presenting prognosis in terms of like what the different pathways look like, and providing a prognosis statement once you understand like what the most likely path that aligns with their like prior wishes, values, preferences is. But I don't know that I have the exact answer because I do think that's one of the hard things that we deal with within critical care. Yeah. Mm-hmm.
Patients may become stuck.
Yeah.
They always require life support.
Mm-hmm.
And you can't prognosticate when like they're just going to die despite the life support like happening before.
Right.
But it's usually a very low probability. So maybe that's the sort of.
And you can prognosticate as to what function looks like, right? You might not be able to prognosticate on survival, but you can prognosticate as to what function looks like and what, if they go down the path of continuing this care, what that looks like. Yeah, Vijay.
What's the evidence on implementation of faith-based practitioners in those types of conversations?
I don't personally know the evidence around that. I don't know if you do. It's a good question. Okay.
Thank you. It's a fantastic topic. I agree that how that can be lighter and throughout the day, and that's important for training purposes. But I think also that can pose challenges for the patient that, of course,
Yeah. You know, I know that there's lots of interventions being designed and tested around communication. I don't know that there's been one strategy that's proven to help streamline that communication. You know, the best case, worst case studies, they often are like having that conversation on rounds and trying to include like the family, either in rounds or in presentation of like what best case, worst case, or time limited trial looks like. And so I think that's one way, but I don't know that there's been one specific like studied way to streamline that communication.
Yeah, I agree. I mean, most of our observation of this is anecdotal, right? We just see it work well when teams come together rather than having the multiple visits and multiple sources of information, especially because patients get stuck and families get stuck on some inconsistencies, right? And that may break that trust.
All right, well, perhaps we can move into a couple cases.
Yeah.
We'll see what time allows. And so as we move into the cases themselves, as someone who participates frequently in the ethics case conference, I will caveat this by saying, like, we're doing a broad sweep of these cases. We're not going to get into all of the like nitty gritty medical information and social information. And so we're going to make some sweeping statements about some approaches that may be useful in handling a case like this, understanding that in like the context of actual patient care, there'd be a lot more time and detail spent on understanding all the different aspects. Oh, it's this one. All right, so I will just read this. Mrs. S is an 82-year-old woman with metastatic colon cancer. She received first-line chemotherapy, but declined second-line treatment due to poor tolerability and concern for future side effects. She was not a surgical candidate. During her last oncology visit, hospice care was discussed. She declined it after an informational meeting with the hospice liaison, expressing hesitancy about signing a DNR, and because she felt too well for hospice. She was lost to follow-up for about a month. She called her oncologist's office with shortness of breath and new severe abdominal pain. She was instructed to call 911. In the ED, she was found to have bowel perforation, peritonitis, and sepsis. She's hypotensive and altered, not a surgical candidate. Her only son living in another state was identified as her surrogate and received information by phone. He requested all available interventions, full code, vasopressors, and ICU escalation. So to briefly just digest like where we are medically, this patient, I think unambiguously is at the end of her life in the setting of bowel perforation without the option for surgery. And while treatments like vasopressors, antibiotics, intubation may temporize the end of life process, ultimately she will pass from this illness. So thinking first about how we might approach this from an ethics standpoint, we don't have information about the conversation that occurred with the son, obviously here. So we're going to elicit his understanding of the medical situation, what his knowledge is of the patient's preferences, what her prior wishes have been around decision-making in the context of her illness, and what his understanding of his role currently is as a surrogate decision maker. We have the information that she declined hospice previously, but one tool that can be used is to set up that the situation has clearly changed from where she was at during her prior clinic outpatient visit. And then I think this case brings up like non-beneficial or potentially inappropriate treatments, which we do encounter from an ethics consult perspective, not infrequently. I think that one of the tools is to talk as a medical team to reach an alignment of what care may be non-beneficial and consider making a recommendation to the son and eliciting his opinion or assent. I do think this is a situation in which a recommendation would be very appropriate based on the medical context of where we are, as well as what we know somewhat about her prior preferences around decision making. And I just put this up here because I think that this policy statement from these multiple critical care societies can be helpful when thinking about responding to requests for potentially inappropriate treatments in the ICU. Hopefully you'd be able to work through this case with communication principles, but this does walk through a stepwise process.
Yeah, and I think that this was just supposed to be like a bread and butter case to showcase some of the, but it's not bread and butter, right? It's very complicated, but to showcase some of the basic communication strategies. And truly sometimes that initial conversation is not very comprehensive. It is a crisis situation and decisions are being made quickly. So I think communication-wise, it's really important to set up that comprehensive conversation that really does feature values, preferences, maybe even shares information with the family member they weren't aware of about the prior things that we have found in the chart about the patient. And I think ultimately when treatments that are, maybe more aggressive are offered, I think a strategy actually is to align yourself with the patient's and the family's choice, right? Especially with the surrogate's choice, right? That is a communication strategy, but also when aligning, expressing worries, right? The idea that I understand that this is your decision. I worry that even when we do this, it may not help. And I think I recommend at least we set up another meeting and reconvene and see in a couple of days how we're doing. And again, I think Hannah's already touched on this, using those recommendations, both based on your clinical judgment, but also the patient's values after you have elicited them. And if it's really a request for non-beneficial treatments, what's guiding that? Asking yourself, like, what's guiding that? Is it grief and a need for more time? Because then you're going to respond more to emotions and really nurture those emotions. Is it actually understanding of the clinical illness? You have to go back and talk about what do you understand and kind of build up with knowledge, that framework, and really to recenter the surrogate decision maker around utilizing patient's values. Should I read this one?
Sure.
Yeah. Mrs. C is a 62-year-old woman with recently diagnosed aggressive diffuse B-cell lymphoma. She delays and eventually declines curative intent chemotherapy after getting multiple opinions at various medical centers, preferring naturopathic and alternative treatments due to concern for side effects with R-CHOP. Months later, her disease progresses rapidly, leading to severe neutropenia and septic shock. She then expresses a wish to pursue chemotherapy, but is now ineligible due to poor performance status and multi-organ dysfunction. While hospitalized, she meets with her oncology and palliative care teams for a family meeting. They recommend comfort, focused care, and DNR/DNI based on her clinical situation and her values and worries. Mrs. C acknowledges her prognosis and the recommendation, but is ambivalent about final decision, saying, "I'm not sure how it will all work." When the palliative care fellow begins to explain the pulse form, she says she needs more time to think and does not want to make rash decisions. Her code status ultimately after that meeting remains full, and that weekend, Ms. C develops CNS complications. She becomes unable to participate in decision making. She's transferred to the ICU where she receives mechanical ventilation, vasopressors, and dialysis. So this is the case of very much of the ambivalent patient and the one that's unable to come to a final decision, even if there's goals and preferences that are being communicated.
And so I think for both of us, when we thought about this case, we were thinking both from a preventive approach, like how we could have, hindsight 2020, but how we could have prevented the situation from happening, as well as an approach of like, what do you do now? So, I talked about decisional preferences in my talk in the context of surrogate decision makers, but I think there's also opportunity to elicit decisional preferences of patients. We alluded to the fact that this is an ambiguous patient who has expressed values and preferences around how she wants to receive her care, but is having trouble getting sort of to the final decision point. And so does she want less or more decisional control? Like maybe it would help her to actually allay some of the stress of the decision making, and knowing what her values and preferences are, help her along to that final decision. Or potentially, if it's not from the clinician perspective of having the clinician have more control of that decision, engaging family and friends to also assist in supportive decision making. I think now that the situation is different, she's unable to participate. We're going back to the basics, identifying her surrogate decision maker, eliciting their perspective on prior wishes, values, and preferences, sharing the medical information, and making a recommendation.
Yeah, and again, the preventive approach here is, some of the things that we sometimes will frame it as, and this is again Hannah's point, a framing technique, is that decision paths, when you are more proximal to death, have lessened. There's fewer decision paths, and sometimes we communicate that in a way that maybe sometimes is not a decision that is up to us, the clinicians, use the family members. It's a decision that's made by her and her body, right? And I think that lessens that blow that patients and families are actually feeling, surrogates are feeling, that they are causing the death of their loved one rather than allowing the dying process to continue uninterrupted. Addressing decision paths inconsistent with clinical situations is really important, because sometimes you will get patients and family members rather saying, I want to live, I want her to live, and you may scratch your head because you thought that you've explained ways that's not possible. But truly, I think that sometimes maybe is like a grief response, I think that revisiting that as, again, is it illness understanding that's prompting that, or is it actually grief and emotions? Discussing implications of the non-decision for the preventive aspect here is very important. So we teach this in palliative medicine a lot. The idea that when you have not made a decision, you've made a decision. You made a decision to continue the current level of care. And are you okay with that? So in the preventive approach, maybe to this patient, it's before you adjourn from the meeting, is saying, well, truly we have made a decision. This is the decision we made. Is this really the decision that you want? Because it didn't sound like that based on your goals and values. I call this limit the sign and the dotted line approach, right? So I think that both like documents and forms, they have their place in medicine, absolutely, but a pulse form is an hospital DNR, right? So that case was specifically, maybe that is not the right time to introduce a pulse form, as it can be another thing that's very overwhelming, rather than making a recommendation and getting some essentially a joint decision on the spot. And that can also be communication that's really signing the dot, boilerplate communication. So it's really important to summarize for patients and families what you've heard, but that summary should not be some boilerplate language like, what we've heard is that you want to forego life-saving treatments, right? So you already frame that as a forego and life-saving, or treatment she may need. And that framing is very important. So I think when summarizing it, not to use boilerplate language, even though, we didn't give a lot of examples in that case, but that's one strategy you may use. And then the corrective approach, back to the basics, right? You're engaging a surrogate decision maker. You are getting illness understanding. You're revisiting values and preferences, prognoses, and recommendations. I think that's probably all we have time for, right?
So we'll skip ahead to our thank you slide.
Yeah.
But thank you all.